Thank you, and thank you for inviting me to be here. This is such an exciting conference, especially all the crosstalk. I'm really enjoying it, and not the least of which is all the baby pictures. So, I don't get to show baby pictures very much, so there's mine. These are my disclosures, and they are minimal. I also am very grateful to NIH, and especially NHGRI, for funding that has supported the data that I'm going to be showing you. The program that I direct is we call it a catchy Genomes to People, G2P. It's really, that's just because that's more interesting to say than translational genomics and health outcomes. But the idea is the impact and downstream consequences, both medical and social, of what happens when genomic information is shared with patients, with physicians, and in the realm of public health. And this is really consistent with the plan from NHGRI to support research throughout this entire life cycle, and obviously ours is more over here on the right, advancing the science of medicine and improving the effectiveness of healthcare. So that's the orientation that I come from, not from a tradition of ethics or law, but from public health and outcomes oriented research. So I'm going to go today through, I cherry-picked some data from a number of our studies that I think will be of interest to this conversation. So bear with me as I go through. Most of you know that we started the REVEAL study back in 2000. It's continued through today through 4 separate randomized clinical trials. And that especially when we began, the notion of disclosing ApoE risk information for Alzheimer's disease was very scary. This is how it felt to us, to our IRB, and I couldn't even go to a conference like this without having a number of people stand up and believe that we were really putting people in danger. Using this paradigm, this very scary disease, this very robust risk factor, but nonetheless probabilistic risk factor, we've been really talking for over 10 years about the danger of genetic risk disclosure. And as you're going to see later in this talk, I'm not cavalier about that danger, but I think our data and others have now pushed some of the burden of proof that genetic risk information, at least from a psychological point of view, is dangerous onto those who would claim it and demonstrate it. As you'll remember, the very first REVEAL trial was a randomized clinical trial that simply looked at people who received ApoE risk information versus those who didn't. I'm only going to show one slide from that. We've published many things, but this slide is actually a pie chart of individuals who were approached systematically to become involved in the REVEAL study on the left. And on the right is a pie chart of people who heard about the study and came and volunteered themselves to be part of the study. And I want to pause on this slide for a moment because I think it is at the root, at the heart of so much of the misunderstanding about this, or at least the discordant understanding about the impact of genetic risk information. What we've continuously found in the REVEAL study and is that when people, the people who ultimately agreed are in yellow, is that when people are interested and say they want this information, then they do well with it. And when, as a clinical medical geneticist, when I have sat with families who never wanted to learn about a genetic risk, who never wanted to, this was forced upon them because of a dysmorphic child or some family history, it can, of course, be very upsetting. So one of the themes that I'm working my way around to thinking about is that if sort of properly informed, and that doesn't necessarily mean hours of counseling, but if properly informed, people may be pretty good at self-selecting if they want information. And that self-selection may be pretty good at sorting out those who will do well with information from those who might not do so well with information. So that's one important question, because it's going to circle back to my remarks about population-based screening versus people who are asking for information. Now, we've done 4 separate clinical trials with the revealed study. One of those we nicknamed diluting the disclosure, which means that in addition to learning about your risk for Alzheimer's disease, this is unpublished data, but the trial's been completed, people in one randomized arm got a surprise. They learned that their ApoE actually also gave them a risk for heart disease. And I want to just show you 2 slides from these data. First of all, everybody did pretty well. The results, here was the randomization. In one arm, people just learned their ApoE and AD risk disclosure. In the other arm, they learned their ApoE, and they learned that their ApoE was relevant to their risk of heart disease. Same direction, the E4 variant tends to give you an increased risk of heart disease. And 2 slides. One, when they learned that they were E4 positive, just for Alzheimer's disease, they said, by the way, they were going to do more exercise. This is consistent with our previous findings because there's some indirect evidence that exercise might help protect you against Alzheimer's disease. People either knew that or they just thought exercise was good in general. But of course, when they learned that they were at risk for heart disease as well through this E4, many more of them reported that they would exercise. Okay, this makes perfect sense. Wow, I learned I'm at increased risk for heart disease. I better double down on my exercise. But look at this blue column here, the 19% column. It turned out that even when you learned you were not at increased risk for heart disease by virtue of this particular variant, just injecting the concept of heart disease into the discussion got people thinking about and released reporting that they would do more exercise. Isn't that interesting? The framing effects of this information cannot be overstated in terms of what people take away from it. But here was the really cool part. The amount of distress, now all of this distress is well below sort of clinical thresholds, but we have this fairly sensitive test for distress called the IES. And again, the blue columns are the people who just got their Alzheimer risk alone, whereas the yellow columns are their cardiac risk. And the distress levels, when you learn you're E4 positive, and that's all you learn, are up here. They're significantly different at 6 weeks from the people who learn they're E4 negative. Okay, it's upsetting to learn this. It actually passes. It's not too clinically relevant, but it's real. People don't like to learn that they're at increased risk for Alzheimer's disease. So far, so good. Turns out when you tell them the exact same thing, but you now add in you're also at risk for heart disease. Now, to me, that's 2 pieces of bad news. I'm at risk for Alzheimer's disease and I'm at risk for heart disease. But look at the level of distress. Again, simply by injecting into the conversation that you're at increased risk for something that you can perhaps do something about, people experienced less distress. This may be part of the reason why when you get these large panels, as you get with consumer genetics, you find your elevated risk on some things and lowered risk on other things, it all kind of emotionally washes out. Anyway, direct-to-consumer genetic testing is, I think, a fascinating naturalistic experiment in incidental or unexpected findings. I mean, after all, nobody, not even us who've done these tests, knows all 70 or 80 things that they're going to actually put on the panel. So you're getting this result back, and some of it's, oh, I didn't know they were even testing for that. And again, we've done an NHGRI, we've just completed an NHGRI-supported survey of consumers of 2 companies. Again, I'm only going to show you a real cherry-picked piece of data here, but first of all, people do like to talk about these results. Now, this is a very select group of customers. They're big on the internet. They're big into sharing. So they're going to talk about it with their, they intend to talk about it with their friends and their family, and their colleagues, and some of them even with their PCPs. Very few of them intend to talk about it with their genetic specialists, even if they had access to one. So that's kind of bad news for we who are in genetics and feel like they should want to talk to us about it. But here's something about healthcare utilization that we're all concerned about. What happens when you learn unexpected risk information? And it turns out that, yes, indeed, a certain number of people, about 10%, decided to make a point, about 20% total, decided to make an appointment with a healthcare professional based on their consumer genetics results. And about 10% in 6 months had already had some sort of test or procedure or examination. So this is consistent with some of the Bloss articles and some of David's work that a percentage, somewhere around 10% of people take this and they do something with it that they otherwise would not have done. And it's hard to imagine this is not going to increase healthcare costs and possibly downstream iatrogenic situations. Now, can we extrapolate any of this to whole genome sequencing in the practice of medicine? Remember that when we're talking about the numbers of variants that we are going to see there, we go through a filtration system in which we use a lot of different criteria, protein criteria, predicted impact, the frequency in the population, clinical issues, if this is a phenotype-driven study like the family segregation, and we do all that in order to get to a certain pool of variants that are at the moment going to have to be manually assessed. That manual assessment is becoming more and more automated, and with the use of things like ClinVar and databases that are now being supported to accrue in Heidi Ream's U41 and others, there's going to be, we all know these databases are rife with errors right now, but there will be better and better databases, and there will allow more automated across-the-board analyses of whole genomes in order to come up with variants that can be considered causative if you're looking at a particular child or someone with a known genetic syndrome, or that can be predicted to be highly relevant to potential future syndromes. Now, you can set those thresholds. This is the tricky part. You can set those thresholds. You can say, I only want to set in this threshold variants that have been seen before and have been associated with pathology. And even there, of course, you're setting those thresholds in a way that is most relevant to families with these disorders, not to the general population. So whenever we're going to be talking about sort of various degrees of screening, whether we're talking about population screening, opportunistic screening, or in essence screening of genes in a given person with a phenotype, we're going to be talking about pre-test probabilities. And we're going to have the option to set those thresholds high and identify only a few things that might be responsible and risk missing things that could be responsible, or low, in which case we're going to generate a lot of sort of false positives about things that could be responsible for disease. This is really important because we've got now by convention 5 stages that most molecular pathologists use. And the 2 stages that we concentrated on in the ACMG recommendations were known pathogenic. They had truly been well associated with the disease, or likely pathogenic, meaning this kind of variant and this kind of mutation had been seen closely associated with a disease in the past. It's important that we understand this thresholding because many companies that are coming onto the market are delving into the variants of unknown significance, in particular because they're finding out that in any given healthy individual, there actually are very few of these likely pathogenic and pathogenic variants to report. So if you're a company and you want to report a marketable report to an individual consumer or even to their physician, if you're going for the doctors, you don't want to send back a report that says, oh, we didn't find anything. So there's going to be a market-driven pressure to move the reporting more and more in this direction, and then to designate the decision-making, the thresholding, if you will, to the doctor. And we all know that that is going to be a difficult decision for general doctors to make. Now let me show you some concrete examples from a report that we did in which we asked 16 genomic specialists this was a predecessor of the ACMG recommendations, we asked 16 genomic specialists to tell us what they would recommend to a molecular lab that they report back in terms of incidental findings to the ordering physician. That was the text, not to the patient or their family, but to the ordering physician. And I give you 3 individuals here because I want to show you how difficult it is going to be to reach consensus about this. So over here on the left, individual number 1 says, in about 40 of these conditions, I really think people should give back known pathogenic variants. And I think really if you find likely pathogenic, we gave them an example of a truncating variant, a truncating mutation where truncating mutations are known to do harm, but it was novel. So if you have a novel truncating variant, I think those should all go back to about the same people. But if you just have one of these missense variants that's predicted in silico by the computer to be a problem, I don't think those should go back to the ordering physician. So that's expert number 1. Expert number 2 says, I really think you should send back those known pathogenic variants. I'm a little less confident about the likely pathogenic variants, but I think you should send them back with some conditions. And for about the same number of conditions, I think if you get those missense variants, you should send them back too. So that's a very different pattern than expert 1. Expert number 3, it could have been George Church, although he wasn't one of the people, says you should give back almost all of these known pathogenic variants. You should give back almost all of the truncating or likely pathogenic variants, and you should give back all of the missense variants. So these are genomics experts. They understand the complexity of this, and they are in great disagreement about what you should give back to the practicing physician. We asked the same question for children, for minors, people under 18, and the patterns really stayed, although in almost all cases the percentage of conditions came down. Most of the experts did not feel as moved to give back adult onset conditions to the ordering physician. So just to make this real for you, I've now had my whole genome sequence done, and it can be characterized this way. You can take, I've got about 109,000 variants in my exome. If you do them on the computer such that you just single out the ones with high and moderate effect, you can get down to about 11,900. If you then filter them on frequency and only go for the novel, the unknown, or the less than 1%, you can get down to about 1,900. And then if you throw those up against HGMD, you can get down to 16. Well, 16 is a manageable number. So I got 16 moderately or high protein affecting mutations that are rare, that are associated with disease genes. So you would think this is the kind of thing you would give back in some sort of screening program. But every single one of them is like this. Here's the TCOF1 gene. It's associated with Treacher-Collins, a dominant condition. I got a mutation in a dominant condition for Treacher-Collins. Those of you who know what Treacher-Collins is know. Fortunately, I don't have it. And I really want to point out that though I do sometimes, I'm associated with data and ideas that are sort of pushing the envelope on disclosure here, I am not cavalier about this at all. Can you imagine if a pregnant mother in the early stages of her pregnancy gets her blood tested and her fetal genome sequenced and finds out that she has a mutation, gets a report that has a mutation like this? It'd be terrifying and completely unjustified, because when you go into this and actually use high standards for novel variant assessment, this variant is at best benign or leaning pathogenic, not in any sense likely pathogenic. So we have recently been funded as part of the CSER series to do a randomized clinical trial of whole genome sequencing in adults called the MedSeq project. And we have taken 2 categories of individuals, patients with disease, which is more conventional, and a true screening component where we've taken essentially healthy patients. And we have randomized both groups separately into receiving family history or family history plus whole genome sequencing. And then we will be following these. The report will be sent to their physicians. Their physicians' interactions are being recorded and studied, and downstream behavioral, health, psychological, and economic outcomes are being studied in this study. And one of the hardest work we've done is generating the report. How do you report on a whole genome sequence to a primary care doctor? And so we're very excited that led by Heidi Rehm, co-PI, on this component of the project, we have a general genome report that is 1 page long. And we really think that's quite cool. A whole genome sequence reported to a primary doc in 1 page. And just to give you a quick overview of that, we've got monogenic disease risks, which are reported like this. We've got a section on carrier risks. Now, we certainly don't have all of them. We just have a number of them for proof of concept that we'll be reporting back to see how the physicians and the patients handle this. A number of pharmacogenomic associations will be reported in what we hope will be a very understandable format. And in our particular report, we've got blood group antigens, which we had a special interest in. And then deeper in the report, you can get more detailed information. But we really modeling this on what would be an X-ray report. You don't have to understand physics and pixels in order for a primary doc to get a report from a radiology. Now, like other individuals who've stood up here, it's obvious that parents want this information. Someone asked earlier about comparing what people want for themselves and what they want for their child. I just thought I'd throw this up here because with Ingrid Holmes' grant, we have been asking this question in terms of a DNA biobank, and as was alluded to, at least in our hands as well as others, people really want all the research results for their children, and they're a little bit less excited about getting all the research results for themselves. I'll also tell you a little bit about some of our preliminary data in thinking about newborn genomic screening. Like some of the others, but with a bit fewer numbers, we've been asking mothers and fathers on the newborn unit, at the same time they're in the hospital having their baby, whether you would be interested in genome sequencing for your baby. We actually, so that's at least, I guess, what makes us different from these other larger surveys is we're right there on the ward. Got the kid in their hand, and we come in and ask them. And as you can see, consistent with those others, these mothers and fathers are very interested. We wondered if asking them while they were on the unit was a little unfair. Maybe they're stressed a little, maybe they're tired. But we asked them 3 months later, and they were equally interested 3 months later. We also wondered, in either time point, if you ask them, do you want something that might help your baby? Of course, everybody's going to say yes. So we took a group and randomized them into a little tutorial where we stressed everything ambiguous and ambivalent that you could think of to stress in genome sequencing. You might get cancer variants, but you might not understand them. Nobody might understand them. It's going to be really hard to know what to do with it. Really gave them the whole bad news part of it. And they were equally interested. So if we think that simply educating parents about the vagaries of genomic information is going to stop them from at least reporting, we didn't make them give us saliva, but reporting that they want this information on their children, I think we're mistaken. So to finish up with, I'll just review a couple of the problems of incidental findings in clinical sequencing. There's a real question about what's the right analogy here, whether the chest X-ray analogy is the right analogy or the whole body scan is the right analogy when we're talking about incidental findings. Oh, that's what I wanted. I wanted you to see the animation. And so I'll finish up by just reminding us to keep distinguished in our mind the notion of population screening versus opportunistic screening. The ACMG recommendations were truly written for one situation only, which is when you're already getting sequencing for cause, for a phenotype, and you've got a doctor-patient relationship, you've got someone who presumably at least has enough sophistication to order the sequencing, you've got all this infrastructure in place. Can we look for, should we look for, must we look for this small number of additional variants and conditions and report them back? And this is the list. It does include a few adult onset conditions, a number of conditions which are both childhood and onset, and a number of childhood onset conditions. These do diverge from current practices in ways that many people have spoken to. One is that we suggest returning these findings regardless of the age of the patient. The reason that our committee wanted to do this was not to take away the open future of the child in those cases where we're reporting back an adult onset, but because at this moment in history there are going to be millions of sequences done on children where their parents do not have ready access to sequencing themselves. Therefore, at this moment in history, finding an adult onset condition in the infant or child is the only way to discover a potentially life-saving piece of information about that child's parent. I know we can argue with that, but that's the reason. Finally, I think our vision, or at least my vision of the way this is going to play out is that there will continue to be population screening for certain kinds of things that, and as Bartha suggested, really society insists that we care for. There's going to be opportunistic screening associated with the practice of medicine. I believe in some form similar to those that we recommended for the ACMG. And then I think there's going to be something we haven't seen that much of yet, which is creating the sequence as a resource to be interrogated when needed, and so-called book of life, where we're going to have genomic and epigenomics as an evolving reference. So I don't necessarily look up my cardiomyopathy risk when I'm an infant, but when I come to my doctor and I tell him that my grandfather and my great uncle died of cardiomyopathy, my doctor, he or she goes, let's go look at those 57 cardiomyopathy genes and see if you've got any suspicious variants. I think that's where we're heading, both with any kind of newborn sequencing, not the public health model, but the opportunistic or resource model. And that's probably where we're heading in the practice of medicine. If people are interested in our thoughts on this, we have put a whole lot of work into a chapter that's coming out or should be out soon. Be happy to send that to you. And I thank all of the many collaborators on these different studies, because these are all multi-center, very involved studies. Thank you very much.